Welcome to Module 20, Psychosocial and Emotional Dimensions in Chronic Wounds. In this session, we will explore the often overlooked mental, emotional, and social impacts of living with chronic wounds, and how we, as nurses, can play a pivotal role in addressing these human aspects of healing. By the end of this module, you will be able to understand how chronic wounds affect emotional, psychological, and social well-being, identify signs of depression, anxiety, social withdrawal, and stigma in patients with long-term wounds, explore the biopsychosocial model as it applies to wound healing, integrate psychosocial assessment into routine nursing care, and implement effective nursing strategies, support resources, and referrals to ensure holistic wound management. Chronic wounds, such as pressure injuries, diabetic foot ulcers, venous leg ulcers, and surgical dehiscence, are not just physical problems. They can significantly impact a patient's mental health, self-image, and social participation. Pain, odor, drainage, reduced mobility, and frequent dressing changes often lead to embarrassment, isolation, anxiety, and even depression. This emotional toll can negatively influence wound healing, self-care, and overall quality of life. As nurses, we are uniquely positioned to recognize and respond to these psychosocial needs, helping patients heal not just physically, but emotionally and socially as well. Let's explore the biopsychosocial model in the context of chronic wounds. Biological factors include chronic inflammation and delayed healing due to conditions like diabetes and vascular disease. Psychological impacts may include depression, hopelessness, anxiety, sleep disturbance, and emotional fatigue, all of which can reduce motivation and adherence to treatment. Social challenges range from embarrassment due to odor or drainage, to withdrawal from social settings, to financial burden caused by loss of income or access to care. Did you know that up to 40 to 50% of patients with venous leg ulcers experience clinical depression? These mental health concerns can slow healing and reduce the effectiveness of wound care interventions. Here's how specific emotional and psychosocial issues affect wound outcomes. Depression leads to slower healing, poor nutrition, and low adherence to treatment. Anxiety may cause patients to avoid care or become hyper-focused on symptoms. Body image disturbance contributes to low self-esteem and social withdrawal. Chronic pain causes fatigue, irritability, and sleep disruption. Stigma and shame often result in patients concealing their wounds, missing appointments, and experiencing emotional isolation. Financial stress may limit access to nutritious food or advanced care. These challenges aren't just emotional, they have measurable impacts on clinical outcomes. Emotional distress affects the body on a neurochemical level, influencing how wounds heal. This is the foundation of psychoneuroimmunology. Chronic stress activates the HPA axis, increasing cortisol levels, which suppress immune function and slow epithelialization. Depression alters inflammatory responses and reduces tissue perfusion, leading to slower healing. Anxiety increases catecholamines like adrenaline, which impair oxygenation and reduce angiogenesis. So, it's not just behavior. Emotional states directly influence the immune and healing response. To identify psychosocial concerns early, we can incorporate several tools into our assessments. PHQ-9 screens for depression and is validated for use in general medical populations. GAD-7 assesses anxiety severity and helps guide follow-up care. Braden Scale, sensory perception. Subscale identifies risks related to sensory loss or immobility linked to emotional distress. Pain scales like the VAS or brief pain. Inventory help connect physical discomfort to emotional responses. Integrating psychosocial screening into routine wound care helps us track emotional changes over time and offer timely interventions. As nurses, we can support patients' emotional well-being using the following strategies: therapeutic communication, practice active listening, show empathy, and use open-ended questions to build trust. Psychoeducation, Help patients understand how stress, mood, and behavior affect physical healing. Pain management. Use both pharmacologic and non-pharmacologic methods to reduce suffering. Referral. When scores on the PHQ-9 suggest moderate to severe depression, greater than or equal to 10, or suicidal ideation is present, make immediate mental health referrals. Peer support. Connect patients to support groups or online communities where they can share experiences and reduce isolation. Behavioral activation. Encourage small steps like personal hygiene, light activity, or engaging in hobbies. Stress reduction. Teach deep breathing, mindfulness, or guided imagery to help patients manage their emotional responses. Education is a powerful tool for both patients and families. First, normalize emotional responses. You're not alone. Many people with wounds feel frustrated, anxious, or discouraged. Help patients understand the mind-body wound connection, where emotional health directly influences physical healing. Encourage shared wound care, where family or caregivers provide support during dressing changes or nutrition planning. Offer resources for financial counseling, home health services, and social support. Finally, promote goal setting. Let's set a small weekly goal, like walking to the mailbox or applying the dressing yourself. These steps build confidence and self-efficacy in patients. When emotional or social challenges complicate healing, collaboration with other disciplines is essential. Involve mental health professionals when wounds persist longer than 3 to 6 months without progress. Patients show signs of hopelessness, non-adherence, or emotional withdrawal. There's evidence of substance use, eating disorders, or suicidal thoughts. Each team member plays a unique role. Social workers can assist with housing, insurance, or connecting patients to mental health services. Dietitians identify food insecurity or disordered eating patterns. Psychiatrists and psychologists provide treatment for depression, anxiety, grief, or trauma. Physical therapists help patients regain independence, which often improves mood and quality of life. Together, we can address the full spectrum of healing. Research strongly supports the link between mental health and wound outcomes. Patients with depression have slower healing and higher recurrence rates for ulcers. When we address psychological factors, patients show improved adherence to wound care, faster healing times, reduced opioid use, a higher satisfaction and quality of life. These are measurable, evidence-based results, further reinforcing the value of a holistic approach to wound care. In summary, chronic wounds are not just about tissue damage, they affect the whole person. Emotional distress, body image changes, social isolation, and financial strain can all delay healing and reduce quality of life. Nurses are in a unique position to see the whole picture, to connect the physical with the emotional, the biological with the psychological. By offering empathy, performing psychosocial assessments, collaborating across disciplines, and educating patients and families, we can truly help them heal inside and out. Let's continue striving toward compassionate, holistic care that restores not just skin, but dignity and hope.